good afternoon, good evening, and good morning, depending on where you are in the world. I'd like to thank everybody for joining us today for another Interacoustics Academy webinar. Today's topic is the diagnostic and functional evaluation of vestibular deficits in the concussed patient. My name is Darren Whelan. I'm one of the international clinical trainers for the Interacoustics Academy, and I'll be acting as moderator for today's webinar. It gives me great pleasure to introduce today's speaker, Shelly Massingale, who is a physical therapist based in the United States of America.
Shelly's been practicing as a physical therapist in an outpatient medical setting for over 20 years and has specialised primarily in mild traumatic brain injury since 2013. She's a graduate with both an undergraduate degree, a Bachelor of Science in Sports Medicine, as well as holding a master's degree in physical therapy. Shelly actually, since 2013, opened the Banner Sports Medicine and Concussion Centre. And I'm not going to talk too much in detail about that in her introduction because it's better to come from her own words so she can describe her set of clinical day-to-day activities. However, she's focused her treatments and research solely on concussion in the latter years. And she is one of the co-developers of the concussion balance test, which hopefully, if you're not familiar with it, you will be by the end of this webinar, the COBALT test. And she's published many articles that have explored the utility of COBALT, both as an objective measurement of balance for the healthy and injured athletic population. Shelly, whilst doing all of these activities, has also authored 2 book chapters. She's done several peer-reviewed journal articles, both looking at BPPV, this benign paroxysmal positional vertigo we're familiar with, and looking at vestibular therapy for vestibular disorders. She also lectures nationally and internationally, so it's an absolute pleasure for us to have her with us for this webinar to give us some great insight into an area that I find fascinating. I'm sure you do whilst tuning into us, in both looking at the diagnostic and functional evaluation of vestibular deficits in the concussed patient. So with no further ado, I shall hand over to Shelly and leave you in her capable hands.
Well, thank you so much, Darren. I really appreciate the introduction, and I want to thank the Interacoustics Academy for inviting me to speak today. I'm honored and very excited to share some of this information with everybody. To get started, let's just review what the objectives are for this webinar. So one would be to identify and discuss the gold standard diagnostic testing for vestibular dysfunction related to concussion. Also to go over the use of the gaze stabilization test and the dynamic vision assessment when evaluating the function of the vestibular ocular reflex. And then the last objective would really be to go over what Darren has already brought to your attention, the balance test that both myself and Dr. Erickson here at the Banner Concussion Center wrote, which is the concussion balance test, or more commonly known as COBALT, and really the role in identifying postural control impairments in patients with concussion. Before we get started, I would love to tell you guys a little bit more about what I do here at the Concussion Center. So we're located in Phoenix, Arizona, and we're really a multidisciplinary center that looks at one diagnosis only. So since April of 2013, I treat only one diagnosis, which, as you guys will hear a little bit more in the webinar, it's a very complex diagnosis, so it never gets old, I will tell you that. But what's so fun about it is that we have all these different clinicians that are in the Concussion Center. So we're all located under one roof, and so we're really centered around, it's considered an MD model, or a physician-based model. So every patient that comes in will initially start and see usually one of our physicians, most commonly the sports medicine physician. This picture up here on the upper right, that's Dr. Erickson and myself. So Dr. Erickson and I were the ones that started the Concussion Center. And so usually the patients will come and see him or one of the other sports medicine physicians, and then he will determine where the patient should go based on their deficits. So we have a sports neurologist here, so anybody that's a little more complicated will go see him. We have myself and another physical therapist who specializes in vestibular therapy. And then we have a neurooptometrist who really looks at visual deficits related to brain injury. So a little bit different than a standard optometrist. And If this patient requires a neurooptometry evaluation, then most commonly they'll get therapy for their visual deficits, which we have a very specialized occupational therapist that looks at functional visual retraining. And then we have an amazing neuropsychologist, we have great athletic trainers, and then we refer directly to audiology when we need more in-depth testing. So the great thing about it is that if we have difficulty with a patient, we have such a great team of clinicians that help us to really figure out what's happening with each patient. Let's go through a little bit about what is a concussion or a mild traumatic brain injury. And in the United States, this is a very, very hot topic. I think that it's going to be around forever. And really what it is, it's a really complex pathophysiological process that affects the brain. And it's induced by biomechanical forces, which could include, a direct blow to the head, but even if you had a blow to your body and the brain moves around within the skull, it could cause a concussion. But what happens is you have these really kind of short-lived impairments. They're neurological impairments that usually can resolve spontaneously, but sometimes need more in-depth clinical care. And what's interesting about concussion is that anything on a CT or an MRI will be normal. Okay, so all of the structural imaging looks normal. However, there's quite a few symptoms. And in a concussion, with a concussion, you could have loss of consciousness or no loss of consciousness. But the one thing that clinicians will always tell you is that if you've seen one concussion, you've seen one concussion, which is really, they're all so extremely different. So with us being open now for almost 6 years, sometimes I'll have seen the same athlete with 4 different concussions and have 4 completely different presentations. So really the newer research that's coming out is really kind of giving us these trajectories, which is showing, a lot of times concussion is just like a big blanket statement. But what we're finding now is that there's concussion with vestibular deficits and concussion with ocular deficits, and there's concussion with cognitive deficits. So really we're trying to take this diagnosis and kind of narrow it down to what really are the main problems. And what this webinar today is going to be on is really concussion with vestibular and ocular deficits. Really, let's go through the first objective, which is really the diagnostic assessment for concussion. So I'm going to go through this part, not fast, but a little more brief. And the reason behind it is that there are really good webinars within Interacoustics Academy that go through all of these ocular motor assessments. Darren has done one that I think is fantastic. So if you have any questions about the ocular motor testing, you could always refer back to some of these other webinars, because I'm not going to be going into great detail about them. However, I am touching on what we use are kind of the gold standard tests that we like to look at from a vestibular and ocular perspective. So we'll look at the ocular motor assessment, positional testing, and then any additional testing that really I would say would be based on the clinician's assessment. So let's go through gaze stability testing. So the purpose is to evaluate the ability to maintain steady gaze with and without fixation. And we look at smooth pursuit. And with smooth pursuit, what we're doing is evaluating the ability to generate slow foveal tracking eye movements, okay, or following a small object throughout your visual environment. The interesting thing about what we do with concussion is that we look at these ocular motor assessments objectively, but we also like to ask their subjective symptoms, because what happens a lot of times with concussion is that their eye movements will be okay or are within the normal limits, but it really makes them very symptomatic. And if that's the case, then as therapists, what we try to do is develop a treatment plan that will help to improve those subjective complaints when they're doing these specific movements with their eyes. Then we look at saccade testing. So with saccade testing, we're going to examine the ability to make fast eye movements in the horizontal and vertical planes. Same thing, we do ask for subjective ratings with this when we do saccade testing. And we look at optokinetic testing, so recording eye movements as a patient watches a series of visual images, usually the checkerboards or the stripes. And it does require full field stimulation to do this. So we do use the interacoustic products for this. And It is quite stimulating for somebody that's had a concussion, especially more in the acute phases. However, it's great for us to look at and be able to determine both objectively and subjectively how they feel. Lastly is the near point of convergence test. So this is a little bit of a different test. So this might be new to some of you. But really the purpose of near point of convergence is to determine at what distance the patient can bring a fixation target to the nose while maintaining fusion. So really what it is, when does the object double? Okay, so I'm going to show you on this video. What I'm doing is I'm asking the patient to stay focused on the focus stick, okay, and make sure that it's 1. And then I'm going to move the stick towards the bridge of his nose and ask him to tell me when it turns to 2, okay? So with near point of convergence, a normal distance for kids is that it'll usually double at 5 centimeters or less. And for adults, it's more around 10 centimeters or less. Now that's a little different in the literature. I'm giving you general numbers. But if you think about it, if you hold your finger out in front of you about 10 centimeters away from your nose, you should see 1 finger, right? Well, somebody that's had a concussion often will see 2, or it'll be very blurry, sometimes 10 centimeters, 15, even all the way out to 20. And if you think about this with what we do in life, so let's say you're looking at your computer and you have to look down to your desk to check your phone, and all of a sudden your eyes go from a little further away to something really close. They need to converge together so that whatever you're looking at on your phone stays 1. Well, if that near point of convergence is impaired, your phone's going to look really blurry, or it might even look like you have 2. And this is a very common impairment that you see with concussion. It does get better over time, but it's one thing that we really look at and make sure if it's not getting better, within a week or so, then that's a good referral to our neurooptometrist, who can then determine and really see, are your eyes not moving together appropriately? So if you do this test on a patient, sometimes what you'll see is as you move the target towards their nose, their one eye will just kick out and just go out on its own. And that's really what's happening, is that they're suppressing that eye and they're trying to still make things 1. And that's another good sign to say that their near point of convergence is impaired. Just good to note so that you get them to the right clinician if that were the case. But then we also look at positional assessment. So, the one thing we do know about BPPV is that the one known cause is when you hit your head, right? So with concussion, that's usually what's happening. So we do find BPP to be quite common in people that have had concussions, not as often in younger kids, but we do see it occasionally. So we test for it, and we look at, we do the Dix-Hallpike, the lateral canal roll test, and positional assessment. And then for recommended testing, we can do VHIT, which we have in our clinic, and we as vestibular therapists do that often. We're actually looking at a study to see, how does VHIT, are we getting positive findings in more acute concussions? Sue Whitney and colleagues did publish an article that with more post-concussion syndrome, or I think the time frame was around 6 months or greater, they found the VHIT to be negative, but we're wondering if more acutely we might see a little bit more positive findings. So that's a test that we can always use. We also have looked, I think VEMPs are amazing, awesome to do when it comes to concussion. The one thing that I don't do VEMPs, obviously I'm a physical therapist, but when I get the results of the VEMP testing, it definitely changes my treatment plan. It also usually will tell me that there's usually going to be a little more prolonged recovery. So it's always good for me to know that and to see really what the results are of that. And lastly, doing an audiogram, which would be recommended if there's any ringing in the ears or any oral pressure. So now I'm going to go a little bit more into detail on the functional assessment of concussion. So this is really, for me as a physical therapist, what I love to do the most. I absolutely love this equipment. I love the results that I get. And so what we're going to go over today is really looking at dynamic vision assessments. So, the VHIT can tell us if there's a semicircular canal problem. The dynamic vision assessment is going to tell me what's happening with the function of the VOR. Okay, and for physical therapists, that's kind of our love. Our love is to really, we're all about function. So there's an impairment, but I want to know how the VOR functions, okay? So there's two tests that we'll go over today. One's called dynamic visual acuity, which I think a lot of people are pretty familiar with, but I'll still go into detail on it. And then there's the gaze stabilization test, which is another test we'll go over to look at the function of the VOR. And then we'll go into detail on the concussion balance test. So we'll look at how well the VOR functions, and then we're going to look at a test that we can look at postural control and balance and really put an objective measurement on that. And then how can we use COBALT to determine kind of recovery from concussion. So before we go through everything, I'm going to go through a little terminology that might be new to some of you. So, and I will let you know, we'll go into detail on all of these, but SVA is considered static visual acuity. So your static visual acuity is really the smallest optotype, or the letter E when we're talking about dynamic vision, that one can see with their head still. So really it's, what is your visual acuity? Visual processing time is the amount of time the optotype must remain on the screen for the correct identification of the target. This is a test we do when we do computerized dynamic vision assessment, and I'll go in detail about that. And then we have dynamic visual acuity, which is the smallest optotype one can see with their head moving at a constant velocity, ideally around 100 degrees per second. And then the gaze stabilization test is the fastest head speed that one can achieve while still clearly identifying the optotype size. We have COBALT, which is the concussion balance test. And then lastly, the visual motion sensitivity test, which is really, it's a term that's, I really haven't heard it specifically described as this until concussion became so well known. But it's really a common term that we use to describe visual vestibular mismatch, but that really occurs with VOR cancellation activities. So we'll go through that when we go over COBALT. So let's start with dynamic vision testing. Dynamic vision testing is done. If you're going to do it computerized, we use the Burtec product, which is called the Burtec Vision Advantage package. So what we do with dynamic vision testing is it identifies VOR impairments. It can determine interaction with balance control. It'll allow for data-driven treatment decisions, and allows for functional outcome measurement. Really, why do we isolate dynamic vision impairments? And really, in my opinion, as a physical therapist, I definitely want to know this. It makes a big difference on almost all diagnoses. As Darren had told you, prior to me working in the concussion center, I worked in an outpatient vestibular neurological rehab center, and I used all of this equipment on everybody. So you can do these tests with people that have vestibular disorders, head injuries, more traumatic brain injury, elderly patients, any neurological disorders. And then really the other thing that you can do, which I hadn't done before coming into the concussion center, is it really can look at high performance athletic activities. And you can do kind of performance enhancement based on this. So there's so many uses for this. So I guess that's one thing, that with all of these tests that we're going to go over, it's not just for concussion. This webinar is focused on concussion, but we definitely want to remember we can do these tests with almost all types of patients. So let's look at the VOR. We all, and most of us, I would assume, understand the VOR fairly well. For physical therapists, this is kind of the meat and potatoes of all of our treatment. I love the VOR, and it's fun to do things related to the VOR because it adapts so well, and it really compensates well with therapy. The VOR allows us to maintain stable vision while our head is in motion. Okay, so anytime we have an impairment of the VOR, that's where we get the sensations of dizziness, blurry vision, we get nauseous. People have a hard time saying they focus with activity. I have many times patients tell me they feel like their brain is sloshing around in their head, and that all is related to a VOR impairment. So when we test dynamic vision, or the VOR more dynamically, what it's going to do is it's going to give us objective measures of changes in visual acuity with head movements. How clearly do we see with our head still versus how clearly do we see with our head moving? And it's going to give us kind of more information on how well your patient is compensating. And it really looks at functions. You could have somebody that has a semicircular canal impairment that actually is compensated quite well, and their VOR functions fairly well, right? You could have completely the opposite. So we want to kind of see from the perspective of function is really how is the VOR performing? So you really are comparing static vision to dynamic vision. The dynamic vision test that we'll go over is we'll first do 2 baseline tests, which is called static visual acuity, which we talked about a little bit before. It's how clearly do you see with your head still, and then visual processing time, which is kind of a screen to make sure you're processing the letter fast enough. And then it leads you into the dynamic test, which would be dynamic visual acuity and the gaze stabilization test. Before I get started on the computerized version of dynamic visual acuity, I want to go over really, I think many people do this test. Maybe we might call it something different throughout the different locations that we're in, but it's really the bedside or more of the clinical version of dynamic visual acuity. Okay, so what we do, and this is how I was taught throughout all of the courses I've been in, is you're going to use a Snellen and eye chart, which this one's very blurry, but it's back here, and I'm going to have the patient read the lowest line that they could read with their head still. And then what I'll do is I'll stand behind the patient and turn their head side to side at a very specific speed and ask them to read the lowest line they can read with their head moving. From there, you compare how clearly they see with their head still versus how clearly they see with their head moving. And a 0 to 2 line difference is considered a normal functioning VOR. So it's a great screen to do this. But I'm going to give you a couple things that you want to take note of as to why it would be better to do it with a computer. So there's a couple things that happen. First thing is we don't really have a standard set head velocity. And the reason behind that is, yes, you can use a metronome, you can turn their head side to side at what you think is a very specific speed. It really makes a difference on how far you move the head, okay? It's not just how fast you're moving it, but how far you're moving it. So there's no really set standard on how fast the head's moving. The other thing that can happen in this test is that, as you're turning a patient's head, I've noticed this a lot when I treat athletes because they're so competitive, is that when you turn, let's say you're going to turn their head to the right, you got to slow their head down and stop moving their head to get it back over to the left. And so what can happen is they can they're not necessarily cheating, but they want to do well. So what they'll do is they'll read the letter when their head slows down, and a lot of times when their head is actually still and it's turning to go the other way. And there's no way to really stop that from happening. Unless you tell the athlete to try not to do it. But so there's just a little bit there's some challenges with the test. It's a great screen if you didn't have the computerized version for this. Let's talk about what happens when you use a computerized version and you have an accelerometer. So here's what you do is that we first get their static visual acuity. What happens when you get the static visual acuity on this system is you're going to get a letter E that comes up. Okay, and you're going to ask the patient to tell you the orientation of the E. If they get it correct, then the E will get a little smaller and a little smaller. Okay, and basically it'll keep getting smaller until the patient can't see it well, and then it'll get bigger, and the computer converges on what's considered your static visual acuity. Here's a static visual acuity report. So basically what happens is that the letter, this is the optotype, it starts out bigger. They get it right, it gets smaller, 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 all the way to where they can't see it, so then they're going to make it bigger, and the computer converges on what is your static visual acuity, which is up here. Some people, I think optometrists use logMAR a little bit more. We are more familiar with 20/20. So this patient's vision is 20/16, so a little bit better than 20/20. Okay, so then what will happen next is now we know their static visual acuity. Then we are going to do this screen called visual processing time. And what we do on this is that the letter E will then come up on the screen at very brief durations. And really what we're doing is we're making sure that your patient can clearly identify the object or the letter when it's on the screen for a very short amount of time with their head still, so that they're able to process that quickly. The reason that we want to do that is we want to make sure that they can clearly see it when it's up there briefly, because when you move their head side to side, what will happen is that the letter's going to be on there for a very brief amount of time. And you don't want to think that there's a VOR impairment when maybe you have a processing problem, okay? So the processing problem can occur, I've seen it mainly with people that have more traumatic brain injury or more significant neurological impairment. I rarely see it with just concussion. So, but it's a great screen. Okay, so your visual processing time should be less than 70 milliseconds. And if it's not, then the computer algorithm will not allow you to test the dynamic portion of the tests, and because you really could just get inconsistent results. If that were to happen, I would just recommend that you would maybe wait until the patient came back the next time, and if it's still that their processing time is very prolonged or longer than 70 milliseconds, then they might need a referral to see an optometrist, or if they have a neurological diagnosis, they may not be appropriate for the dynamic parts of the test. Okay, so our next step is to go into dynamic visual acuity and gaze stabilization testing. Computerized dynamic visual acuity is going to do the same thing as what we talked about with the Snell and I chart. Basically, we're going to get their static visual acuity, so how clearly do they see with their head still, and then we're going to turn their head side to side at a constant head speed, and then see how clearly they can see with their head moving. Okay, so with dynamic visual acuity, what will happen is that we'll get their static visual acuity, and then you'll turn their head side to side, and the E comes up really big. If they get it correct, it's going to keep getting smaller, and then when they can't identify it, it'll get bigger, and it'll converge on what is their dynamic vision. I'm going to show you what this looks like, okay? So on the left is the computer screen that the patient looks at. On the right is the patient that I was treating. I like to do all of my dynamic vision assessments doing passive head movement. Okay, so I actually turn my patient's head side to side when I do this. This is an accelerometer up on her head, so it's telling me how fast she's moving her head, okay? And it's also able to identify if she's moving her head to the left or to the right. So on the computerized version, not only are we standardizing their head velocity, which I was telling you can't do as well with the clinical version, but it's also going to be able to test how clearly she sees when she turns her head to the left versus how clearly she sees when she turns her head to the right. So if you can see over here, there's an R right there. So this one is, right now, it's only going to test when her head turns to the right. I'll move her head side to side both ways. But so let me show you this. I'm going to turn her head side to side, and then here's what it looks like on the computer screen. The E comes up really fast. Say, comes up quickly, and then she is over here identifying whether the E is up, down, right, or left. And I'm entering it in on the remote. So if she identifies it correctly, then the E will get a little smaller. And then if, again, it will get smaller. And then eventually we'll be able to determine how clearly did she see with her head still versus how clearly she saw with her head moving. Here's a dynamic visual acuity report. So basically what happened with this patient is she was able to, so let's look down here at the bottom. The bottom is, I think, the best way to review this. Hopefully you can see it. It's a little bit small. The BLVA is really bilateral visual acuity. So really, how clearly did she see with her head still? So for this particular patient, she had 20/22 vision with her head still, okay? When she turned her head to the left, she had 20/21 vision, which is really reading the same line as she could with her head still, even a little bit better. And this right here, 104, was the average head speed throughout all the trials that I was able to achieve. So the goal is 100, but nobody can get right to 100. So the computer gives you a little bit of a leeway where you can go about 20 degrees higher and 15 degrees lower, so that you're staying within the range of about 85 to 120 degrees per second for dynamic visual acuity. Now when we look over to the right, okay, she was 20/22 with her head still. She went up to 20/50 with her head moving. Average head speed was 97 degrees per second, and so it's a 3.5 line difference. And if you look up here on this chart, it shows you the same thing. So if you remember, a 0 to 2 line difference is considered a normal functioning VOR. Well, this person's at 3.5 lines, so that would be considered an abnormal functioning VOR to the right. Does this diagnose that she has a right, semicircular, horizontal semicircular canal problem? Absolutely not. This is not a diagnostic test. It's really looking at the function of the VOR. Okay. Sometimes what I'm finding in concussion is that I may have a normal V-hit, all the canals are functioning fine, but then I do dynamic visual acuity and there's an abnormal functioning VOR. So really what that means to me is it's not a peripheral vestibular problem, it's that my patient isn't processing the information coming from the peripheral system well, which is giving a VOR impairment. So we have to remember that this equipment and this testing is really looking at functions. And then what I'll find is I can do some retraining of the VOR and the function comes back to normal, which is the most exciting part of it. So there's dynamic visual acuity. Remember, 0 to 2 line difference is considered a normal test. This is great information. So now I know that, okay, her VOR isn't functioning appropriately to the right. But for me, I would love to delve a little deeper into that. And I want to know, well, when is the VOR breaking down? At what head speed is the VOR breaking down? And so that's where the gaze stabilization test comes into play. I love the gaze stabilization test. It's probably my favorite test of everything I do in therapy because it 100% gives me objective information that I can directly do treatment with. And I'm going to go over some of the treatment with you all today too. So with gaze stabilization test, so what it's doing different from the dynamic visual assessment is what it can do is it can tell us at what head velocity the VOR breaks down, okay, or really kind of what we all know better as retinal slip, okay, and it gives us that objective information. So what happens with gaze stabilization is that you'll get their static visual acuity, and remember the dynamic visual acuity test is starts with the E getting really big and gets smaller and smaller and smaller, and it's giving that line difference. With gaze stabilization, it's going to use a constant optotype size, so the E stays the same. And what happens, what changes is your head velocity. So what I'll do is I'll start out and turn the head side to side, maybe at 60 degrees per second. If the athlete or the patient gets the orientation correct, the computer will ask me to increase their head speed. They get it correct, we'll go to 90, maybe to 120. Then if they get it incorrect, it'll slow their head speed down. So what it'll eventually do is converge on a head speed where they're losing the ability to clearly see, okay? Does the same thing as dynamic visual acuity, where I can see how clearly they see when their head turns to the right and how clearly they see when their head turns to the left. So this is like gold for a physical therapist. And what we want to do from there is like, oh my gosh, now I know the head speed that retinal slip is occurring, and that's where I want to train the VOR. Let's go over. So on this is the same patient. Okay, so I tested the patient, and basically let's look up here in this little box and we can see. So when this patient turned her head to the left, she could achieve 150 degrees per second or greater. So in what we consider the normal testing mode, it'll test from 60 to 150 degrees per second. If you get to 150, the computer will say their VOR is functioning really well. Let's test them in high performance. And high performance goes from 150 degrees per second up to 300 degrees per second. For this patient, they could clearly see at 150 degrees per second when she turned her head to the left. However, turning her head to the right was only 80 degrees per second. That's consistent with what we found on the dynamic vision assessment, right? They had a 3.5 line difference with dynamic vision. Well, now what I'm finding is that the VOR is breaking down right around 80 degrees per second. So what I need to do is train the VOR right around 80 degrees per second. So the one thing I want to tell you before we move on is that gaze stabilization and dynamic vision assessment can be done in all planes. So you can do yaw, pitch, and roll. So everything that I'm talking about today is in the horizontal plane, but it is very important to make sure that, and to know that we can test in the vertical plane. I don't do roll ever, but I do yaw and pitch. I think that this equipment is great to look at both. When you get into high performance, it's a little bit more challenging in the vertical plane when you're going at those super high head speeds. But it's important to know that A, we should be testing both. B, we should be training both, because as we walk around, we're moving our head in all different directions. So let's look at what is normal head speed for regular activities. So this is information that was published years ago, 1990, 1998. And basically, driving is about 90 degrees per second. Back then, they said high performance was about 120 degrees per second or greater. I say for my patients that, you want to have about 90 to 110 degrees per second for maybe like people in the community that just are not really active. I think, though, for people that are more active, people from 20 years old to 60, we should be at 150 or higher. This would be my opinion. Then we were seeing so many athletes here that myself and Amy Alexander, the other physical therapist, said, these athletes, I know their VOR functions at such a higher level. And if we're determining when our athletes are going to go back to play and get back into contact sports, we wanted to see, well, what is normal head velocity for elite athletes? So this is a study that's currently under review with a peer-reviewed journal. But we tested minor league baseball players. It was with the Cincinnati Reds, and their average head velocity was 220 degrees per second, with a standard deviation of about 30 degrees each way. So I use 180 to 220 when I have an elite athlete and I want to get them back to play. So, okay, so what do I do with this information? So let's go back to the athlete that I've been talking about. So their VOR was breaking down, turning their head to the right at about 80 degrees per second, right? So I want to train the VOR. This is the most amazing chart. Dr. Cameron Vereen, who also has done some of these webinars, he was able to convert degrees per second into beats per minute for me. Okay, so because I like to use a metronome when I train the VOR. So basically, the first thing you have to do is you have to determine how far is your patient going to move their head. Now, this is going to be subjective, but you want to have an idea of that. And I like to train the VOR with my patient moving their head about 15 degrees each way. So you saw when I was testing that athlete, I was moving her head not very far, and that's really what's recommended, 15 to 20 degrees each way. So I use 15. So that's going to be the yellow line. So what I'm going to do is I'm going to go to 80 degrees per second. That's where the VOR was breaking down. Come up to this yellow line, and it's really 100 beats per minute on the metronome. I will set the metronome up at 100 beats per minute and have my athlete retrain the VOR. VOR exercises are really, a lot of times, they're called many different things. And times 1 and times 2 viewing is what some people call them. I most commonly do VOR times 1. And what that means is that the object that you're looking at is still, okay? So you're having your athlete or your patient focus on a stationary object and then turn their head side to side or up and down, okay, whichever plane that you test them in or where the impairment is. And they hold that for a very specific amount of time. Okay, so I'm going to show you a video of that. I have the metronome set up. She's turning her head side to side, 15 to 20 degrees each way. And she holds that for about 45 seconds to a minute. Okay, and what we're trying to do is that it's not just straightforward with the metronome. You also want to ask the patient to turn their head side to side. If they can clearly see the object and it's not moving or blurring at all, and it's not making them symptomatic, then you might need to speed their head up a little bit. And as they speed their head up, they're eventually going to feel like the object starts to blur or maybe even jump slightly. And that's really kind of where that retinal slip is occurring. And at that speed, that's a speed that you would want to try to train it out, where it's not jumping all the time, but it's not perfectly still, but it's kind of like occasionally jumping, occasionally blurring. And that's really where the learning is occurring, with how your head and your eyes move together. And so that's really how we train. Okay, so now you can also add in more dynamic tasks. Usually I would start with maybe like a plain card. So for her, I already have her on a busy background, but you can start in a very plain environment, sitting down if you need to, and then you move to standing, and then eventually you can do things where you add in a more dynamic task where you're having your patient do like a balance activity. And then I eventually do it in walking. I can do it, with athletes, we're going to put them out on the field. We're going to have them do all types of things where we're really actively stimulating the VOR. So let's just review what we've learned between the two. So DVA and GST compared. So dynamic visual acuity is a constant head speed, okay, versus gaze stabilization is the head speed varies, right? With dynamic visual acuity, the target size varies. So remember, your head's staying at a constant speed, but the letter's starting big, getting smaller and smaller and smaller, and we're looking at the line loss difference, right? With gaze stabilization, the target size is staying constant, and we're changing the head speed, determining kind of where retinal slip occurs or where does the VOR break down, okay? And both of them give you very good information. I would say, if you were to ask my opinion, I will almost always do the gaze stabilization test as long as my patient has a good neck, meaning that they don't have any neck problems, okay? If their neck is a little stiff, if they're older, I think that the dynamic visual acuity test is a better test to do. It's easier to administer, and it's a very constant head speed, and it gives you information on if there is a functional impairment in the VOR. So older people, a lot of times the elderly population, I do DVA on. For athletes, younger, active adults, active older adults, I do gaze stabilization testing. And does this change my treatment plan? Absolutely. This information 100% will help me determine a different pathway on treatment. I also have found that, we do a lot of baseline testing for our athletes. Baseline testing is really testing athletes at a normal state. Okay, so preseason, they come in and we'll test their balance, which I'm going to go over with you next. And then we'll also test gaze stabilization has become a baseline test for us. So interestingly, quick story, these are my two kids. You can believe it, I treat one diagnosis all the time, and my kids play football. They're older now, both of them. He's in college. Matthew is now in high school. But my older one is currently playing football in college, but his junior year, I tested his gaze stabilization prior to playing. Okay, so he was at 150 degrees per second when he turned his head to the left, and 300 degrees per second when he turned his head to the right. He's a quarterback, so he basically was not seeing as clearly to the left as he was to the right, for sure. No concussion, no injury, and so we did VOR training, just like I showed you all in the video. He did that for about 2 weeks, and I tested him again, and he was at 300 degrees per second both ways, and he honestly had the most amazing season he's ever had. And I'm not saying it's only from that, but I do believe that we can really retrain the VOR to a level that will really help enhance these athletes. And the VOR can adapt whether there's an injury or no injury. So I think that's really interesting to know that we can really I think, make people better athletes. I've had so many athletes that have come in and said, I play better after getting my concussion and doing this therapy than I've ever played in my life. So I think that vestibular therapy has a place in really performance enhancement too. Let's go into postural control assessment. So the next thing we'll talk about is the concussion balance test. Okay, so the concussion balance test was really developed by Dr. Erickson and myself and really was meant to be a test to challenge athletes. Okay, so he was having a hard time. Prior to him moving over to the concussion center, he was working at one of the major universities here in Phoenix called Arizona State University. He was a head physician for about 15 years there, and he was having a hard time determining if his athletes had balance impairments following injuries in games. And so he said that he really wanted me to help him write a test that was more objective, number one, and that really gave him more information on how well we're using our balance systems, okay? So really what we did is we determined, first thing is to see what's the difference of a static balance test versus a dynamic balance test. And a static test is really asking somebody to stand as still as they can and just doing whatever task, just stay as still as you can. Okay, a dynamic test would be stand as still as you can while you perform an activity. So that's really, I would call COBALT a dynamic balance test. Here is the equipment that we use for COBALT. So it's very standardized. We've done now almost 6 years of research on it, and I think we've found some pretty significant information. And basically it's done on a force plate, okay, so that it's objectively measuring sway. And then we have a standardized background. The background is used because when we do the dynamic tasks, it's going to tell us how far one should move their head when we ask them to turn their head at times. And then it's also being very standard at how fast they move their head. So let's go through what COBALT is. There's 8 conditions, okay? So conditions 1 through 4 are the same as 5 through 8. So 1 through 4 are done on just the force plate. 5 through 8 are done on a piece of foam. So you stand eyes open on a firm surface, eyes closed on a firm surface. Then you ask the patient to turn their head side to side with their eyes closed. That's condition 3. And then condition 4 is what we call a VOR cancellation task, or really visual motion sensitivity. Okay, and I'm going to show you what these conditions look like. Then you repeat those 4 conditions on a piece of foam. Interesting thing I want to just note here really quickly is conditions 1, 2, 5, and 6 are really what we more commonly know as the modified CATSIB test. On the modified CATSIB, you ask somebody to stand eyes open on a firm surface, eyes closed, and then you get them on a piece of foam so it disrupts their ability to use their feet. And you look at how well they do with their eyes open, and then you have them close their eyes so that they can't use their vision, they have a harder time using their feet, and they're really using their vestibular system for balance. Okay, so that's a great test to do. What we found is that it's just too easy for athletes or for people that have more higher functioning balance or postural control systems. So we added in these extra conditions, which are really more dynamic tasks that actively stimulate our visual and vestibular systems. So let's show you. So conditions 7 and 8 are the ones that we have found to be the most sensitive, and so we spend a lot of time on those. So condition 7 is eyes on foam. So what's happening here? Liz has got her eyes closed, okay? She's turning her head side to side to the metronome. If you could hear that metronome, it's a very specific speed. And she's wearing a headlamp, and the headlamp was telling me how far she moves her head, okay? I'm watching, because her eyes are closed, and I'm telling her if she needs to move her head further, but she's trying to meet those outer lines on the poster or just slightly past them, okay? And then condition 8 is the VOR cancellation or visual motion sensitivity task. It's a slower setting on the metronome. Her eyes are focused on her thumb, okay, and she's rotating in block, left and right, staying focused on her thumbs the whole time with the feet together. Okay, so what's happening is that the force plate is measuring how much movement she has during these tasks, and then the clinician is determining how many errors are occurring. So what is an error? So an error, we tried to make them with as little subjectivity as possible. These are the 4 errors. If you lift your hand off your hip at any time because of loss of balance, you open your eyes during an eyes closed trial, if you step off the force plate or move your feet from the markers due to a loss of balance. Okay, so those are pretty easy to see. The one that I think is the most subjective is the unable to keep up with the metronome for 2 beats or greater in a row. And what can happen with that is it's usually occurs on that condition 7, where you turn your head side to side with your eyes closed, and it happens when people have a concussion or they're more unsteady or off balance. And so what they'll do is they'll turn their head side to side, but they get dizzy and they just stop moving their head, and they don't open their eyes or move their hands or move their feet, but they just don't do the task. And if that occurs for 2 beats or more, we consider that an error because they're not doing the task that we want them to try to do. So let's go over what the research has shown us. So we've collected 5.5, almost 6 years of research. This study right here was just recently published in the International Journal of Athletic Training and Therapy, July of 2018. So basically we were able to look at, this was all normative data. So we looked at 576 athletes, and we were able to break down what their sway scores were, really for conditions 7 and 8. So I told you, and I'll show you why conditions 1 through 6 weren't looked at as much, is that they just didn't yield a whole lot of difference in sway or errors. But with 7, we were able to break down, that's the eyes closed head shake, how much did they move based on age group. So basically you look at the 10 to 12 age group, a higher number means that they're swaying more and they're more off balance. So if this was your number, you'd be in the 5th percentile for balance for your age. You come all the way over here, you're more steady, you're in the 95th percentile for balance for your age. So it's broken down for each age group, and the same thing for condition 8, broken down with each age group. We can look at the error data, so I'll try to explain this to you a little bit here. So on the errors, what we found, now these are all normative data, so these are all athletes coming in preseason, okay, no injury. First of all, 100% of them could do the whole test, right? And 100% of them could do conditions 1 through 6 with 1 error or less. So none of them had more than 1 error. So that's significant. So the one thing I would say is if you tested somebody, you maybe have one of your kids that's going to play sports and they have multiple errors in any of these conditions, it would be considered abnormal, and they really might want to do some therapy prior to playing a sport. However, condition 7 and 8 yielded a little bit more errors, but not that much. So 92% of all of the athletes tested could complete condition 7, the eyes closed head shake, with 1 error or less. Only 8% of them had more than 1 error. And with condition 8, only 2% of them had more than 1 error. So we use in our algorithm, which I'll go over with you, is that we want our athletes to be able to do each of these conditions with 1 error or less. Ideally, no errors, really, but 1 error or less for sure. You can even break down the error data by age group, because what's interesting about this is that within that 576 athlete group, the majority of them that had more than 1 error were these younger kids. And really that's because we know the vestibular system doesn't truly mature until, the literature is a little bit different, but anywhere from age 13 to 16. So we do see more instability and more errors for these younger kids. So I think really what we want to know is, let's compare. For me, that was normative data, so I want to know how people do when they're injured. Okay, so this research was just recently published in the Journal of Neurological Physical Therapy in 2018 also. And what we did was we compared 106 concussed athletes to this normative group I was telling you about. And the 106 concussed athletes were anywhere from 2 days post-injury to greater than a year post-injury. So there's a lot of variation in how far out they were from their injury. Average amount of time was, I think, about 13 days. Okay, but what we found is that at baseline, 100% of the athletes we tested could do COBALT on an uninjured state. Post-injury, those 106 athletes that we tested, 45% of them could not even complete COBALT. And usually it was due to being too dizzy. So the first thing you look at is, can your athlete even do the test? They all can do it at a normal state, but when you're injured, it's pretty difficult. And it's usually because they just get too dizzy when they have to turn their head. So that's the first thing we look at. The second question we wanted to look at was, how many had more than 1 error? Because remember, we're talking about the more than 1 error. And we found that it was statistically significant that on condition 7 and 8, they had more errors post-injury than they did at a normative state. So you look at, can they complete it? Then can they complete it with 1 error or less? And then lastly, what were their sway scores? We did find that there was statistical significance that the concussed athletes had more sway than the uninjured athletes, which you would think. So we want to look at all 3 of those in order to understand if your athlete's ready to get back on the field and play a sport. The one thing that I will tell you that we have been doing now is that we wanted to see if COBALT was appropriate for anybody, not just athletes. So we have been doing some data collection on older, what they call older active adults, and we've got about 250 of them that we've tested. They were all going into what's called the Huntsman World Games. And it's been great. They can do COBALT at a normative state. So their errors are a little greater and their sway scores are a little more. But I think it's a useful test to do with active people. It's not just for athletes. And I'm a firm believer that we should be testing balance where we're really actively stimulating the visual and vestibular systems. Let's look at what we do for the decision tree for return to play. Number 1, can your athlete complete the test? Okay, if they can't, then they shouldn't go back to play. Let's say they can. Okay, if they can, then let's look at what their error rates are. If they can do the test with no errors or one error in condition 7 and 8, then we look at sway scores. If they have more than one error, they're not ready to play, we should do some more therapy. Okay? When we look at sway scores, I personally think that there's no set value on that. So I would say if you have a football receiver and he's going to play in college, I mean, his balance needs to be in the 90th, 80 to 90th percentile for balance. I'm not comfortable if he's in the 30th percentile. So really, there's no set standard. We kind of said between 25th and 75th if you have to put parameters on there, but I really think it's a clinical decision. So quick case study, and then we're going to wrap it all up. So this was an athlete I saw just about a year ago. He was a gymnast. He was level 10, about to go to the Olympics, actually, and he hit his head doing a vaulting activity. He came in about 1 week post-injury, tested him on COBALT. He had 7 errors in condition 3, which was the eyes closed head shake. He could not complete the test. He was too dizzy. Gave him some exercises. He came back a week later. He was able to complete COBALT without any errors. However, his sway scores were at about the 5th percentile for balance for condition 7, the eyes closed head shake, and the 10th percentile for the visual motion sensitivity. So I didn't think that was appropriate for somebody that's that level of a gymnast. I gave him more exercises. He came back on the 3rd visit, which was really about 5 days later, and he was able to complete COBALT. He was in the 95th percentile for both condition 7 and 8. That was an objective measurement that I felt was very good for postural control assessment. Dr. Erickson felt like it was good, so we had more of an objective way to be able to return him back to play. Data for COBALT is useful in that it's a test that's challenging, but it's achievable at baseline, but definitely very challenging if you've had an injury. Really what we want to try to do is think about doing balance assessment that's replicating activities that are more indicative of what we do in life and in sports. And I think that's what the concussion balance test is trying to achieve. In conclusion, when evaluating a patient with a diagnosis of concussion, I think it's important to objectively and subjectively evaluate the ocular motor system. So we do smooth pursuits, saccades, OPKs, and near point of convergence. We should assess the function of the VOR, and we can do that through the gaze stabilization test and dynamic visual acuity test. And when we look at postural control, I think it's very important to assess postural control using a tool that's dynamic, right, and actively stimulates our visual and vestibular systems. Really, what I just said is ideally replicate what we do in sports and life, and I think the concussion balance test is trying to achieve that. So I want to thank you very much for spending this hour with me, and we will take any questions.
Thanks very much, Shelly. That was an absolutely fascinating webinar and presentation. We've got a couple of questions coming in. I'll just read through them for you. Our first question has come in from our mutual friend, Michelle Petrak, and she says, "Hi Shelly, great talk. Really useful information for me as an audiologist. I have a question about the convergence insufficiency. Can you see something in the patient's eyes that tell you they're beginning to get blurry, or do you depend on them telling you that it's blurry or getting double?" She asks this because she would guess that many athletes, being high performers, will the pen or target is blurry because they want to return to play.
Well, that is an amazing question, and hi Michelle. Thank you for listening. So there is one thing you can see. First of all, if I had mentioned, there's multiple times where they will try to suppress that turning to double. So when you move the target close to their nose, you always want to watch their eyes, because they may say, "Oh, it's still one, it's still one," but one eye literally jumps out to the side and almost just isn't even involved in the task anymore. And so that is where you would eventually measure the distance for sure. So that's one thing you can look at. The other thing that'll happen is that you can watch their reaction. And you're exactly right. Athletes lie because they want to go back to play, and different than you see with a lot of other people. So they're going to try to tell you that it's fine, but if you watch their face, you watch what their reaction is, a lot of times they'll actually move their head back. And that's showing that that it's starting to double and they're trying to kind of fake it. So those are two things that you can look at. But very, very good question.
And Michelle comes with a second question, and actually it's a question that I would have asked myself, so she pipped me to it. She asks, I would assume that there is a relationship between abnormal V-hit gain and the presence of saccades and DVA impairments. Are you investigating this relationship?
We actually are, yes. And so I think that that's a very, very interesting thing to look at, all of those. And what we're going to do is we want to look at abnormal V-hit gain, DVA, saccades, really looking at acute concussion versus, concussion that's what you would almost term like post-concussion syndrome, which would be, greater, that's different in the literature for everybody, but maybe greater than 6 weeks post-injury. So I think we're going to see something in relationship to those, especially in acute concussion. So we're actually in the process of collecting that data right now and analyzing it.
Oh, fantastic. I think we'll all be riveted to see what that relationship is. We've got a question coming in from Sherman. Sherman has asked whether GST is administered if DVA is normal.
Oh, what a great question. Such a great question. Absolutely. So if DVA is normal, then I know that the vestibular ocular reflex is functioning fine at 100 degrees per second. But what I want to know with gaze stabilization is, can they move their head faster than that? So I will do gaze stabilization tests on everybody because, like I had said, in the literature, 90 to 110 degrees per second is considered normal. But I think you need to move your head faster than that in activities of life. So I would test gaze stabilization and make sure that they can get to 150 degrees per second, and maybe even test faster than that to see where their VOR breaks down.
Sherman's got a nice follow-up question, actually. He said, during the MPC, are you estimating the distance, or do you measure the distance when you perform the trial? And do you perform more than one trial?
Yeah, very good question. You should do 3 trials, and then you average the 3, okay? And if you're going to do research, you definitely want to measure the distance with, there's multiple pieces of equipment that can help you do that, or you could just tie a piece of string on the end of your vision stick, and when they say it doubles, you pull it up to the bridge of their nose, and then you just measure it on a ruler. I measured it for a while, and then after you do it for quite a long time, you can kind of guesstimate. So it really kind of depends on if you're going to do research 100%, you need to measure it. If you're in the clinic and you're a little bit strapped for time, sometimes I'll just kind of guess and get a good idea of where it is. Great question. It really comes down to how objective you really want to be. And you should do 3 times because you're going to notice that it changes throughout the 3 times.
His question is the COBALT the only factor used in determining if the athlete is ready for return to play?
Sherman, you have very good questions. No, I don't use just COBALT. So I am fortunate, you guys saw in some of the pictures, I have computerized dynamic posturography, so I use that. I go a lot on making sure that they don't have any subjective. If I only had COBALT, that would be my objective tool. But the one thing we have to remember is that concussion is a myriad of symptoms. So COBALT is one small piece of the overall, picture when you're going to return somebody to play. So I could use COBALT to help me return somebody to play based on postural control. But then I'm also going to test their gaze stabilization. Okay, so we don't release somebody back to play if their gaze stabilization is not back to normal, but COBALT is, right? They both need to be back to normal. I like to do the sensory organization test on the CDP. And then we move all the way over to the cognitive pieces. And there's the neurooptometrist piece. So we have all these different things that are helping us return somebody to play. So I kind of try to make everybody realize, there's not one tool in concussion that's the end all. But I think when you put them all together, you can get a good picture of when your athlete is ready to get back on the field.
Excellent, excellent. Well, thank you once again, Shelly. We've got thanks coming in from Michelle there, and people joining, and Cami saying thank you as well. So I think what we'll do is we'll bring this webinar to a close now. And again, thank you for all the participants that have joined us from various locations around the world. We do appreciate you tuning in for our webinars. And once again, this will be available on the Interacoustics Academy website within about a week's time, so you can pass that on to colleagues. Certainly I'll be reviewing it again because there's so much information in there that has got us thinking very much about functional testing. So again, on behalf of Interacoustics Academy and all of our participants, Shelly, I'd like to thank you for spending your time and sharing your expertise, and we hope to hear from you again very, very soon.
Thank you very much.